welcome to the module on organophosphorus poisoning. So in the next slide, I have just summarized everything regarding organophosphorus poisoning. So this slide or this picture can be very helpful for the last minute revision. But let's start with the organophosphorus poisoning. So the mechanism of action. What is the mechanism of action of organophosphorus compounds? So they inactivate acetylcholinesterase. Acetylcholinesterase is an enzyme which is responsible for breakdown or degradation of acetylcholine when it is not needed. So when acetylcholine is not needed, suppose at neuromuscular junction, when the muscle want to relax, because acetylcholine is a mediator of muscle contraction at neuromuscular junction. So that is when acetylcholinesterase comes in and breaks acetylcholine and muscle relaxes. Apart from its function at neuromuscular junction, acetylcholine is also responsible for glandular secretion. It is responsible for cardiac regulation, BP regulation. So it has lot of functions in the body and it is a mediator of parasympathetic nervous system. So if there is increased level of acetylcholine due to the inactivation of acetylcholinesterase, which is the enzyme responsible for breakdown of acetylcholine, then what will happen? There will be lot of acetylcholine in the body. So when there is lot of acetylcholine, it will stimulate its receptors. So what are the receptors for acetylcholine? The receptors of acetylcholine are muscarinic and nicotinic. So the symptoms due to the increased stimulation of nicotinic receptors are called nicotinic symptoms, and the symptoms due to the increased stimulation of muscarinic receptors are muscarinic symptoms. Okay. So what are nicotinic symptoms and what are muscarinic symptoms? Let's go here first. So muscarinic symptoms are, which is due to the increased stimulation of muscarinic receptors, are meiosis, that is constriction of pupils, increased glandular secretion, respiratory distress and cardiac symptoms. These four categories comes under muscarinic effects. Nicotinic effects are muscle fasciculation, weakness, paralysis of respiratory muscles and limb muscles. So as I said before, there will be lot of acetylcholine at the neuromuscular junction. So it will keep stimulating the postsynaptic membrane. So muscles will get stimulated. Muscle will, will be stimulated again and again. So that is why there will be fasciculation. And if the muscle is getting stimulated again and again, it will be fatigued. So there will be weakness. And in the late stages, there will be paralysis of respiratory muscles as well. So it is a life-threatening emergency. OP poisoning is a life-threatening emergency due to this. Muscarinic effects, meiosis, increased glandular secretion, respiratory distress and cardiac symptoms. In terms of central nervous system effects, in early stages there will be anxiety, there will be confusion, there will be seizures, but there will be no loss of consciousness in mild OP poisoning. In moderate to severe OP poisoning, there will be coma, respiratory depression, loss of consciousness and all those things. So these are the side effects of OP poisoning. These are the effects of OP poisoning. Now coming back to this slide, how does acetylcholinesterase get inactivated? What happens, like at molecular level, what happens which inactivates the acetylcholinesterase? So acetylcholinesterase get inactivated via phosphorylation. What do we mean by that? Organophosphates have a phosphate group and acetylcholinesterase has a serine residue. So both these entities, phosphate group and serine residue, makes a phosphate bond or a covalent bond. This phosphate bond or covalent bond, phosphate bond is a type of a covalent bond, is a very strong bond, and as it ages, as this compound ages, this bond gets stronger and stronger, and when this bond gets stronger and stronger, it will be very difficult to break this bond. It will be very difficult to reactivate the acetylcholinesterase even by giving oximes, and this is called aging. So we will discuss that again. Aging happens because this bond gets stronger as it ages. So in the exam or in the viva or in any particular scenario, they ask you that apart from acetylcholinesterase, what other enzymes get deactivated by organophosphorus poisoning? So answer is butyrylcholinesterase. Butyrylcholinesterase is a pseudocholinesterase. Why it is called a pseudocholinesterase? Because it is not specific to acetylcholine. So if it is not specific to acetylcholine, it will not have much effect on acetylcholine, and there will be no muscarinic symptom, there will be no nicotinic symptom because of inactivation of this enzyme. So that is why the toxicity of organophosphorus poisoning is mainly due to the inactivation of acetylcholinesterase. It is not due to the inactivation of butyrylcholinesterase. That is why in the mechanism of action we only mentioned acetylcholinesterase. We have not mentioned butyrylcholinesterase. So why butyrylcholinesterase is then important? It is important because of its diagnostic value. It is easier to measure. When it is easier to measure, we can just take a blood sample and we can measure the activity of butyrylcholinesterase, and we will know that what is the status of OP poisoning. So why this enzyme is easier to measure and this enzyme acetylcholinesterase is difficult to measure? Acetylcholinesterase is more important in terms of OP poisoning, then why are we not measuring acetylcholinesterase? Reason is that acetylcholinesterase is present on the surface of RBC. So this is RBC. Acetylcholinesterase is present here, but butyrylcholinesterase is present in plasma. So it is more readily accessible, right? That is why it has more diagnostic value. Some studies or trials suggest that it has a protective effect in cases of OP poisoning. You can read it here. I have taken a paper, I have taken a snip because I find it interesting, and you can read it here. Butyrylcholinesterase for protection from organophosphorus poisons. Clinical features we have already discussed. There are three kinds of clinical features: muscarinic effect, nicotinic effect, and CNS effect. Muscarinic effects are meiosis, increased glandular secretion like salivation, lacrimation, rhinorrhea, and all those things, respiratory distress, and cardiac symptoms. Nicotinic effects mainly pertains to muscles, and central nervous system effects are anxiety, confusion, seizures, coma, respiratory depression, loss of consciousness, all these things. So let's differentiate between mild, moderate, and severe OP poisoning. In mild OP poisoning, muscarinic symptoms will predominate. So muscarinic symptoms appear early as compared to nicotinic symptoms. So if there is little exposure to organophosphorus compounds, mainly the secretions will be increased. Patients will be salivating, patient will be having secretions from the eye, they will be urinating, rhinorrhea, so secretions will be increased. Mainly muscarinic symptoms predominate. Nerve gas is a good example for this. If you have seen police throwing nerve gas at a mob, then what happens? Will they get paralyzed? No, they don't get paralyzed. They will only have water coming out of the eye, and they will be coughing and all these things, but they will not get paralyzed. Why? Because it is a mild exposure, and as it is a mild exposure, only muscarinic symptoms are there. So in mild poisoning, muscarinic symptoms will be there, and early nicotinic signs like mild fasciculations may be there. There will be headache, anxiety, but there will be no altered consciousness. This you can remember from if you have seen nerve gas poisoning, if you have seen police throwing nerve gas at a mob. So people will have anxiety, people will have headache, but there will be no altered consciousness. They may have mild fasciculations, but they have a lot of secretions. Their eyes will be wet. So that is how you can remember this mild OP poisoning. In moderate OP poisoning, muscarinic symptoms will become more prominent, and nicotinic symptoms will also increase. In mild poisoning, there was mild fasciculations, but in moderate poisoning, there will be muscle weakness. And in severe poisoning, there will be copious secretions. There will be marked bradycardia. This is also a muscarinic symptom. Bradycardia is a muscarinic effect. Bronchospasm will be there, massive wheezing will be there, hypoxia will be there. So all the muscarinic symptoms will show up in severe OP poisoning. And there will be flaccid paralysis of respiratory muscles. In mild OP poisoning, we had fasciculations. In moderate OP poisoning, we had muscle weakness as nicotinic symptom. But in severe OP poisoning, we will have flaccid paralysis, not weakness, paralysis of respiratory muscles. And there will be loss of reflexes. In mild poisoning, we will have headache, anxiety, no altered consciousness. In moderate OP poisoning also, we will have no loss of consciousness, but there will be confusion and restlessness in addition to headache and anxiety. And in severe OP poisoning, we will have seizure, coma, and loss of consciousness. Clear? Now, acute cholinergic syndrome. In acute cholinergic syndrome, like what we have studied till now is acute cholinergic syndrome. It is an immediate symptoms or sign that happens after the exposure. So whatever nicotinic effect or muscarinic effect we have studied till now, due to the inactivation of acetylcholinesterase and buildup of acetylcholine, is acute cholinergic syndrome. Both muscarinic symptoms will be there and nicotinic symptoms will be there, and we give atropine and oximes. Okay, this is acute cholinergic syndrome. Cholinergic means due to acetylcholine. So atropine mainly takes care of muscarinic symptoms. Atropine takes care of muscarinic symptoms. But oximes take care of nicotinic symptoms. Mainly pertaining to muscles. So if you give atropine, all the secretions will dry up. Your respiratory, your bronchial tube will be dried up. Patient will be able to breathe. But if you give oximes, all the muscle-related effects will be resolved. So oxime is for muscles and nerve, and atropine is for secretions. We will discuss that again. Intermediate syndrome. Intermediate syndrome happens 2 to 4 days after the exposure. 2 to 4 days after the exposure, if treatment is not given properly. So what will happen if treatment is not given properly? There will be prolonged and recurring inhibition of acetylcholinesterase. So there will be increased acetylcholine. So this acetylcholine will keep on bombarding the neuromuscular junction. So what will happen? Muscle will be damaged or neuromuscular junction will be damaged. The pathogenesis is still not clear, but there is some amount of muscle or neuromuscular damage in intermediate syndrome. And what are the hallmark features of intermediate syndrome? Respiratory distress, proximal group muscle weakness like neck or hip or shoulder. These are the proximal group muscles. Neck flexors will be involved and there will be cranial nerve palsies. So because respiratory distress is there, lot of respiratory distress is there, we need to give respiratory support in intermediate syndrome, and we need to give high dose of oxime therapy as well. Coming to delayed polyneuropathy, it happens 1 to 3 weeks after exposure. So it happens due to the inhibition of neuropathy target esterase. It has nothing to do with acetylcholinesterase or acetylcholine. There is a separate enzyme called neuropathy target esterase which gets inhibited in delayed polyneuropathy, and there will be axonal degeneration. One thing that is important to remember in delayed polyneuropathy is that all the signs and symptoms will present in lower extremities, not in upper extremities. So there will be glove and stocking paresthesia in the lower extremity. There will be leg cramping and calf pain in the lower extremity, atrophy and paralysis of peroneal muscles, foot drop, ataxia, loss of Achilles and ankle jerk reflexes. So all the symptoms will be there in the lower extremities and happens due to the neuropathy target esterase inhibition. Now I want to ask you a question. Suppose a patient of organophosphorus poisoning comes to you with acute cholinergic syndrome. You give oximes and you give atropine and the symptom resolves. Will you discharge the patient? No, you will not discharge the patient. Why? Because there is a possibility that intermediate syndrome can develop. There is a possibility that delayed polyneuropathy can develop. So you will keep that patient under monitoring for at least 6 to 8 days to rule out the possibility of intermediate syndrome and delayed polyneuropathy. Differential diagnosis. So as we know that there will be increased secretions in the OP poisoning due to muscarinic effects. So there will be increased gastric secretions and there will be gastric cramps as well because of the muscarinic effect. So we can confuse it with gastroenteritis. And because there is bronchoconstriction, we can confuse it with other respiratory diseases as well, like asthma, pneumonia, influenza, carbon monoxide poisoning, all these things. There will be a lot of sweating, so we can confuse it with heat prostration, heat exhaustion, heat stroke. CNS symptoms, there will be neurological disorders, subdural hematoma, epidural hematoma, meningitis, encephalitis. So these CNS symptoms in these diseases can be confused with OP poisoning. Hypoglycemia, present with lot of sweating, so we can confuse it with OP poisoning. Ketoacidosis, sepsis, Reye's syndrome, narcotic overdose. So these are the differential diagnosis of organophosphorus poisoning. Basically, wherever you see the increased secretions or wherever you see the respiratory compromise, so those diseases can be confused with organophosphorus poisoning. Coming to management, if you suspect organophosphorus poisoning, first thing that you will do is to stabilize the patient. You will check ABC, you will give oxygenation, and you will intubate the patient if needed. Then you will remove the clothes and you will decontaminate the patient. One thing important to remember is that when you are decontaminating the patient as a healthcare provider, you need to have double gloves, you need to have a gown, you need to have an eye shield. Why? Because organophosphorus can affect you as well. It can be absorbed from the surface of the body. So you need to protect your eyes, you need to protect your hand, you need to protect yourself. So decontamination. In mild exposure, we monitor the patient, we observe the patient, and we give atropine if symptom persist. And if the patient is asymptomatic, we discharge after 6 hours. Because in mild exposure, there are less chances of intermediate syndrome, there are less chances of delayed polyneuropathy. But if the exposure is moderate or if the exposure is severe, then you atropinize the patient and you also give oximes, 2-palm. 2-palm means Pralidoxime, 2-palm. It is Pralidoxime, which is an oxime. We will discuss about that. And if there are seizures, you will give diazepam as well. So see, in moderate exposure and in severe exposure, it is saying observe the patient and treat complication. What complications? Intermediate syndrome and delayed polyneuropathy. When the patient is complication free and there are no symptoms, you can cease the sedation, you can extubate the patient, and you can discharge. So in moderate and severe exposure, you observe the patient and treat complication, intermediate syndrome, polyneuropathy, and you atropinize and you give oximes as well in moderate and severe poisoning. But in mild exposure, you just give atropine. The oximes are not needed. We will discuss why oximes are not needed. So decontamination we have already discussed. We will remove the patient from exposure, we will remove the clothes, and we will, as healthcare provider, we should protect ourselves also. Like we will have gowns, masks with eye shield, and use double gloves. Atropinization. I have briefly mentioned that atropine mainly block muscarinic symptoms. That means it dries up secretions. It mainly works with secretions. It has no effect on nicotinic symptoms. If there is paralysis, if there are fasciculations or weakness, all these symptoms are nicotinic symptoms. So atropine will not resolve nicotinic symptoms. So no effect on nicotinic receptors on muscle weakness or paralysis. It does not affect the rate of degeneration of inhibited acetylcholinesterase. This is done by oximes. Oximes regenerate acetylcholinesterase. Okay. So mydriasis is an early response. When you give atropine, the pupils will dilate first. But it is not a therapeutic endpoint. Even if the pupil dilates, you will not stop the atropine. That is what we mean by it is not a therapeutic endpoint. So what is the therapeutic endpoint? When we will stop the atropine? Let's see. The main endpoints for adequate atropinization. That means when you can stop the atropine, when you have clear chest on auscultation. That means there are no secretions, there is no fluid in the bronchial tree, there is clear chest. Heart rate is greater than 80, systolic BP is greater than 80, and there is good urine output. What do we mean by that? This means hemodynamic stability. So when the patient is not in respiratory distress and patient is hemodynamic stable, then only you can stop atropine. Pupil should be moderately dilated and reactive. This is in addition to these points. Do not confuse that I have said mydriasis is an early response and it is not a therapeutic endpoint. It is not a therapeutic endpoint. It means, like by this I mean that only mydriasis is not an indication to stop the atropine. So when we study atropinization, we usually say that when we think that atropinization is complete, so our answer is dilatation of pupils. But in this case, we will not stop atropine once the pupils dilate. We will stop atropine when the chest is clear on auscultation, heart rate is greater than 80 per minute, systolic BP is greater than 80 mmHg, and there is good urine output. And also pupils are moderately dilative and reactive. This is just one of the points. There is no salivation, sweating or lacrimation. That means muscarinic effects are over. Muscarinic effects are over. There are no muscarinic effects. There are no salivation, no sweating, no lacrimation. So if you stop the atropine and there is no recurrence for 12 to 24 hours, then only you will discharge the patient. So you will monitor the patient after stopping the atropine for 12 to 24 hours, and if there is no recurrence, then you will discharge the patient. Oximes. Oximes helps in the regeneration of acetylcholinesterase at neuromuscular junction. They should be started early. Why? Because we have discussed that the bond between organophosphates and acetylcholinesterase gets stronger with time. As it gets stronger with time, it will be very difficult to break that bond with oximes also. So that is why we should start the treatment early. Best effect on nicotinic symptoms, as we have already discussed before. Atropine has best effect on muscarinic symptoms, and Oxime has best effect on nicotinic symptoms. It improves muscle fasciculations, muscle weakness, respiratory muscle paralysis, all related to muscles, autonomic ganglia effects, and improves survival when given early. So this early treatment is very important, because as the aging happens, the bond between acetylcholinesterase and organophosphorus compound will get stronger. So this is what we call aging in OP poisoning. So phosphate bond will get stronger over time. Treatment will not be effective after a certain time. This happens because of the loss of alkyl group. So this bond gets stronger because of the loss of alkyl group over a period of time from the OP acetylcholinesterase bond. This dealkylation creates a more stable and irreversible bond, and the agent enzyme can no longer be reactivated by oxime antidotes. It is as simple as that. So timing of the treatment is important. I think this is clear. I will just say this again. So there is a phosphate bond between acetylcholinesterase and organophosphorus compound. This bond will lose the alkyl group as the time passes by. This loss of alkyl group make this bond stronger and stronger over time. So when it gets stronger, we will not be able to break this bond even by oxime antidotes. So we should not waste any time, and timing of treatment is important in cases of organophosphorus poisoning. Supportive care. We will raise the foot end of the bed to drain the respiratory secretion. We will do the suction as required. We will treat bronchospasm with atropine and not bronchodilators. Why? Because this bronchospasm is due to the secretions. Secretions are irritating the bronchial tree and it is getting contracted, or its lumen is getting narrower because of the secretion. Bronchodilators are mainly used in asthma or COPD patient, where the bronchial contraction is due to the contraction of muscles and not due to secretions. Here we need to dry up the secretions so that patient can breathe. So bronchospasm is treated with atropine and not bronchodilators. Intubate if needed. Other medications that can be used are antibiotics, vitamin K, dextrose, but we will not use opioids because opioids cause respiratory depression, and we are already struggling with the respiratory system. Patient is not able to breathe, so we will not give anything that further depresses the respiratory system. So opioids are not used. Coming to the nightmare called agriculture poison classification. So based on chemical composition, alkyl phosphates, agricultural poisons are classified into alkyl phosphate and aryl phosphates. So how will you remember? So there is a mnemonic: toothy daisies handled thirsty managers. So toothy trichlorphos, daisies dimethox, handled HETP, thirsty TEPP, managers malathion. Toothy daisies handled thirsty managers, if you can remember that. Aryl phosphate. Peter picked cute daisies. Every boy will remember that. Please call dad. Every girl will remember that. Okay. So Peter parathion, picked paraxon, cute chlorothione, and daisies diazenon. Similarly, please call dad. So try to remember these mnemonics. But even if you can't remember all of these names, suppose you remembered there was something called toothy daisies. So you know two names, right? And there was something called thirsty managers. So you now know thirsty managers, You now know tooth disease, so you are okay. So try to remember them, but if you can't remember them fully, even half is okay. You should know some names. Agriculture poisons classification. So agriculture insecticides. This is easy to remember. So who does the agriculture? Farmer. So just visualize a farmer doing PT in the farm. PT means physical training. Remember we used to do PT in our schools. So PT. So P is parathion, T is TEPP. Animal insecticide. So remember two animals, rat and tiger. First letter, last letter. T, trichlorophone, Ronal, R. Household insecticides. So we have mattresses in households. Or you can say mat. So you remember M and T, malathion and TIC20. That is how you can remember. So agriculture, visualize a farmer doing PT in the farm, and from PT you can remember TEPP and parathion. Animal, you have to remember rat or tiger, first letter, last letter. Household, you have to remember mattress. Common OPs. There is a mnemonic for that again. Cold days make dreamy plains, trees and green grass. So here also, if I would be you, I would just remember this much. Cold days make dreamy plains. I have 5 names now. C, D, M, D, M, P. I have 5 names. So these 5, remembering 5 names in the exams are enough. Nobody expects you to write the complete list. And this is not even the complete list. I have taken this list from a book, but there will be number of OPs. So even if you can remember this, cold days make dreamy plains, you will be good enough in exam. Common carbamates. Cute puppy comes going proudly, now playing elegantly and always. I don't know what sort of mnemonic is this, but you can remember this if you want to, or you remember half of it. You remember this much: a cute puppy comes going proudly, or a cute puppy now playing elegantly. Whatever you can remember. So you will have 5 to 6 names. I have given you the mnemonic for the whole list that is given in the book, but you can remember 4 or 5. Now coming to the differentiation between carbamate poisoning and organophosphorus poisoning. In organophosphates, the bond is irreversible. Remember that phosphate bond between the phosphate group of organophosphates and serine residues of acetylcholinesterase? That bond is irreversible in organophosphate poisoning, and the bond ages over time. But in carbamate poisoning, this bond is reversible. So it is a milder form of poisoning. This carbamate poisoning is milder than organophosphate poisoning. Okay. It typically less than 24 hours because it is milder, generally less severe than OP poisoning. Less likely, central nervous system toxicity is less likely in carbamate poisoning, and there is low risk of intermediate syndrome or OP induced delayed neuropathy, the syndromes we have discussed earlier. So it is a reversible and milder form. It is non-reversible and a stronger form, a more severe form. In organophosphate poisoning, aging happens. We have discussed aging already. That means that there will be a loss of alkyl group, due to which the phosphate and serine bond, the phosphate bond gets stronger over time. This happens in organophosphorus poisoning, not in carbamate poisoning. Carbamate poisoning is reversible binding of acetylcholinesterase. So duration can be prolonged due to aging of the OP-AChE bond, typically more severe. Central nervous symptoms will be more severe and more common in organophosphate poisoning, and there will be high risk of intermediate syndrome or OP-induced delayed neuropathy. So we don't give oximes in carbamate poisoning. Why? Because this is reversible poisoning. The OP and acetylcholinesterase bond will break down by itself. We don't need to give oximes to regenerate acetylcholinesterase. So oximes are generally not recommended in carbamate poisoning, but they are effective in OP poisoning because this is irreversible bond. So we need something to break that bond. So what we need? Oximes. So atropine and oximes are standard treatment in organophosphate poisoning, and atropine is the standard treatment in carbamate poisoning. I think this is clear. Absorption. Organophosphorus compound get absorbed by transdermal, transconjunctival, inhalational and direct injection. And most OPCs are hydrolyzed by enzymes, esterase and peroxygenases, which are not inhibited by it. So if there is an OPC in the body, it will eventually get passed in urine. Why? Because it gets metabolized by esterases and peroxygenases. Medicolegal aspect, we have already discussed that we need to hospitalize the patient for 4 to 6 days to rule out intermediate syndrome and to rule out delayed polyneuropathy. So we have to hospitalize the patient. We have to keep the differential in mind. Accidental poisonings can happen in places where insecticides are stored, pesticides are stored, like manufacturers, packers, sprayers, and in children. Accidental poisoning can happen in children. Suicidal poisoning is common because people drink rodenticide, like the housewives or the ladies. It is especially so common in the rural areas where females just drink rodenticide and they come in the emergency that चूहे की दवाई पी ली. So suicidal poisoning is very common. Homicidal is rare. And OPCs residue in fruit and vegetable. This is very important because we use pesticides. Farmer use pesticides when farming. So certain residue can remain on fruit and vegetables. So that is why we should always wash fruit and vegetables before consuming. So OPCs are really harmful, as we have seen before. PM findings. So because the secretions are increased, everything will be congested, everything will be hemorrhagic, everything will be edematous. Let's see. Kerosene-like smell. This is due to a solvent which is mixed with OPC compounds for maybe better shelf life or whatever. Sinuses of lips will be there because of the respiratory distress. There will be deep postmortem staining. There will be congested face. See, everything will be congested. Everything will be frothy. Often blood stained from nose and mouth. Because there is, like, all the body secretions are increased due to muscarinic effects. Internal PM finding, mucosa of the stomach and intestine is congested, again congested. Stomach contents may give kerosene-like smell. Respiratory passages are congested, frothy, hemorrhagic exudates, petechial hemorrhages. So can you see that these are the what do you call this froth and this congestion is happening because of the increased body secretion. Antemortem secretions were increased. Edema and congestion of lungs and other visceral organs, edema of the brain. So fetal dose of malathion and diazinon is 1 gram, parathion 15 to 30 milligram. So that is from my end. If you like this video, please like, share and subscribe. And if you have any feedback for me, just let me know. Thank you.